Good afternoon, everyone, and welcome to the webinar. My name is Kieran Stevens, and I'm also joined by my colleague, Nicola Pinocci, today. On behalf of Williams Medical, I'd just like to take this opportunity to welcome everyone to this webinar on the impact of diabetes, the diabetic foot. So this webinar is presented in partnership with Essity, and we are delighted to welcome Jane Mays from Essity today. So welcome back, Jane, and thanks for joining us this afternoon once again. Just a couple of bits in terms of housekeeping. So time-wise, this webinar is scheduled for 1 hour, but this will include plenty of time for questions at the end of the session. With regards to questions, we'd like to invite your comments and questions throughout the session. So if you do have a question, please use the chat function, which should be at the top of your screen. And one final point, this session will be recorded and will be available following the webinar, along with some useful materials from the session as well. So without further ado, I'd like to hand over to Jane to start the session.
So thank you so much, Kieran, and thank you for inviting me back to present. I'm Jane Mays, the Clinical Education Manager here at Essity. I've been a nurse for 30 years and I've still got an honorary tissue viability nurse contract at the Christie Hospital in Manchester, which keeps me really clinically grounded. Today we're joining this afternoon to look in the next hour at the assessment and referral and understand the patient with a diabetic foot ulcer. So I've set us a few objectives for today, and I'm going to take you back to some of the anatomy and physiology of diabetes, and that's going to be a real recap for everybody, but I'm going to simplify it, strip all the real academicness out of it and get us to really be on the same page around what diabetes is all about and how we assess our patients. Focusing today on the foot, and then we're going to look at foot ulceration, and we're going to look at other complications associated that come on the back of diabetes with our patients in foot ulcers. And then hopefully we're going to understand where to signpost, where to refer to, and it's all built on nice guidance, information, and some work done by the National Wound Care Strategy on foot ulceration. I'll share the references at the end of today's presentation. Okay, so let's first of all look at the burden of a diabetic foot ulceration. And it's really interesting for us to look at this in relation to sort of like the patient and also those patients that we see in clinic. I know a lot of you today are practice nurses. For those patients with foot ulceration, which is associated to diabetes, they're really at risk of amputation. We know that. However, what's interesting for us to also know that any patient with a foot ulcer is at risk also of amputation, because those come on the back of arterial disease, peripheral arterial disease, and also they need rapid assessment and referral. The reason I highlight that is because I was community tissue viability nurse in Leeds, and I saw lots of patients with foot ulceration. And I hate to say, I almost was pleased when there was that diabetic focus, because the pathway of care was very different to those patients that presented with foot ulceration but had no diabetic or diabetes diagnosis. So the message to that statement is all about everybody with a foot ulcer should be treated, escalated appropriately, because the risk of amputation is equally as great for those patients without diabetes as it is with diabetes. So looking at some of these startling facts around diabetes and those patients, there's lots of patients, 4.7 million people with diabetes, and, of those patients, 500 people with diabetes die per week. So it's a huge health economic burden. But from a mortality, morbidity perspective, the condition we know has great risks and carries great risks. So this focus now is thinking around let's look at how it impacts with regards to other medical conditions. And I think this was quite interesting for me to cull this data and look at it from, it was published in 2020, looked back at data from 2007 really, so things will be greater even now. But people with diabetes, the mortality for those patients over the next 5 years from diagnosis is huge. It's up there with other conditions that we wouldn't necessarily associate it with. So you can see on this graph mortality at 5 years for lung cancer is high in its percentage. But when we look down to amputations and, peripheral arterial disease, those are high, along with just a diabetic foot ulcer mindset. So it's up there. Its mortality is great when we're thinking around patients with this presentation. So we do need to recognise diabetic foot ulceration or the at-risk foot early on in our patient's journey. So to be able to do that, I want to use that first objective that we've set this afternoon to simplify diabetes and what does it actually mean, the anatomy and physiology of it. I use a really good analogy for this because diabetes, we know, is, in its simple format, it's a common condition that we see. It's lifelong and it's where somebody's body, with regards to the amount of glucose in somebody's blood is too high. And that's the simplified way of thinking. And this is either due to the patient's body producing enough insulin, but that insulin response and there's insulin resistance going on, or it's due to the fact that they have no insulin production. So the way I want to simplify it for us this afternoon is I want to look at what happens when we eat food. So obviously we eat food and it's broken down into glucose within our bloodstream. It enters the bloodstream and then very simply, the pancreas is producing insulin. Think of that insulin as like a key to the cell. And this is where I really found, I had a light bulb moment when I sort of attended an education session on diabetes. Think of the insulin as the key to the cell. And, that insulin then will open up the cell and allow glucose to enter into the, sort of bloodstream and into the cells themselves. So when we think of it in this way, it's almost like those keys of the insulin, when they're overworked, and you can imagine them opening up the cells, allowing the glucose in, everything's, working great. But when they're overused, and there's patient scenarios where we can really think now where that would be the case. So in patients with obesity or high level of sugar intake, I relate to my teenagers here at home and I go, all that glucose that you're eating, your poor keys, your insulin is having to really work really hard to keep opening the sort of cells up and allowing the glucose in for it to do its job. So when we think around type 2 diabetes and we're thinking about those patients, they've got insulin, they've got those keys, however, they are not working in the way that they should. They're resistant to all the element of exposure, the amount of glucose in there. Whereas in type 1 diabetes, those patients there, that means that they have no insulin to produce. So there's been a damage, and that complexity of that type 1 diabetes is still being questioned and explored about an early onset. Is that a viral presentation? It's wiped out all the cues, is the way I like to think of it. So just to recap, to simplify, keep diabetes simple. Use this analogy, this very simple analogy, to explain it to your patients. They eat the food, that's broken down, enters the bloodstream, the glucose does. The keys are the insulin. Insulin opens up the cells, and then obviously the glucose transferred into the cells, the energy, etc. That's the normal process. With diabetes, those keys shattered, exhausted, however you want to put it, the insulin can't do its job or isn't there to do its job. And then that becomes an issue to that patient because what happens is the glucose sits in the bloodstream and causes all the damage and complications that we associate with diabetes. So I'll just pause for a second there, let you absorb this picture, let you simplify it back into your minds. If you get a textbook out on diabetes, you're lost in the first few chapters. Let's keep our understanding very, very simple. Okay, so moving on now from this, we've now got this understanding of diabetes and what that means. And we've looked at that type 1 and type 2 diabetes, thinking around that lifelong condition type 1, where insulin producing cells have been destroyed. And like I say, we looked at that. There's no keys to unlock the cells. we're not really that sure, but we do think that, there's this triggered by a virus or an infection early on in life, and it happens to children. I've just got a friend whose daughter's just been diagnosed, and the symptoms were classically there, but then led to this diagnosis of type 1 diabetes. These days, their blood glucose glycemic control is very tight, and you're very familiar with that. There's a lot of insulin pumps being introduced. So the management of type 1 diabetes is improving with time, and life expectancy and quality of life is hugely improved. Type 2 diabetes is one where, you've got that issue where the patient themselves, the body's unable to regulate the amount of glucose because the insulin is either resistant or the person is not making enough insulin for the amount of glucose that's going through the system. So it's tired cells, tired keys, exhausted keys, unable to work effectively when we're thinking back to our key analogy and insulin. It's increasing the amount of patients that are presenting with type 2 diabetes. And, of those patients that have type 2 diabetes, you have patients that need insulin injections. When I look back to early days in my community nursing career, we used to talk about insulin dependent and non-insulin dependent. And now we've moved that thinking into this type 1 and type 2. Type 2 patients can still need insulin. So our knowledge and understanding has definitely evolved over time. The majority of patients with diabetes are type 2. You can see there, 90% of patients with diabetes have type 2. So we're thinking and we're managing a large number of patients with this condition. What I will say to you at this point, though, is, and I speak from experience, if you've got patients in your care where wounds are not responding in a way that you would expect, so wounds are not healing, progressing, do a HbA1c and see if they have type 2 diabetes. There's so many patients out there undiagnosed, and it may be that non-healing wound or non-progressing wound that triggers your thinking in clinical practice to think, I'm going to screen this patient for type 2 diabetes. Recurrent infections can be another one. So never let diabetes be back on your mind when you're caring for those patients that come through clinic. So taking you now on a journey, we've looked at what diabetes is. I've stripped it back and made it really simple, and we'll revisit that before I close the presentation. So if that's the one thing you take away today, at least it's been of benefit to your knowledge base today. We've then moved into sort of like the type 1, the type 2, what does that mean? What does that look like? So let's focus a little bit more with that and think about that patient presenting to us. What are the risk factors? Again, we're familiar with a lot of these and we know them, but it's just time today to just reset our thinking and explore them in a bit more detail. Age is a factor, as we get older, over 40s, and think of that as those poor keys. They've been working a long time to open that insulin. Those keys have been working a long time to open up cells, allowing glucose in. And if over time, you've become, as you age and you've had a lot of exposure to high levels of glucose, I always think of them being really tired, those keys. They've done lots of work over time. And then there's some research around if you're African, Caribbean, Black African, South Asian, there's a higher risk with regards to diabetes. I was lucky enough to sit within a project that was looking at beating diabetes in Bradford, and that project really identified just different types of dietary intake, and it was looking at sort of like processed and takeaway foods and such like, which really did increase the incidence of type 2 diabetes and that undiagnosed presentation. So again, thinking about obesity, we know this, we know about diet, we know high levels of glucose are a big no-no when we're thinking around the diabetes intake presentation. I know my sons here will go to the shop, a small bar of chocolate is more expensive than a big bar. Our whole diet, the way we look at diet, takeaway foods, and McDonald's, everything that we think about really impacts on this prevalence and incidence and this extending prevalence of type 2 diabetes. It's out there. We're getting a bigger population, literally. There's other things in there as well with regards to alcohol intake. It says in the literature that regular excessive intake of alcohol puts you more at risk, and that being over the recommended 14 units, etc., a week that a person can consume, or heavy drinking on 2 or more days of the week. So we do this. There's nothing new that I'm exposing you to today. It's all about just looking at your patient who presents in front of you. What are the risk factors when we're thinking type 2 diabetes? Huge impact on mental well-being and mental health as well there. And, with regards to sort of like those other health problems, so hypertension, peripheral arterial disease, that we know patients have multiple comorbidities these days. They're living longer. It's more of a risk to those patients. So we're getting there. We're getting towards the foot. However, before we do that, let's again think of the other impacts that diabetes has on our patients. And this is where my friend's daughter got presented, always thirsty, always tired, passing lots of urine. The body is naturally trying to expel all that glucose. With regards to neuropathy, which we're going to look at in a moment, tingling, numbness of the fingers, and eyesight issues, all these issues will impact on a patient when they've got diabetes, and they may just present and tell you in other consultations that they're experiencing issues in these areas. That one close to my heart, the wounds that don't heal, and we've already touched on the needs to exclude a diabetic diagnosis or diabetes diagnosis. So thinking now, we're getting to that lower limb and to that foot. It's important to think that, with regards to all these symptoms and signs that a patient presents with or complications of diabetes, they a lot of the time are associated to the damage that these high levels of glucose do. The damage that they do to the large blood vessels in our body, and the damage that they do, which is the macrovascular circulation, or the damage that they do to the very micro, the very small blood vessels within the body. And that will have a huge impact. The big vessel damage will have an impact on that patient's heart and the stroke issue, whereas the smaller ones, the microvascular system that's impacted, it will have a problem with nerves and eyesight and kidney damage. So we know that these are issues to our patients that we see, and it's all to do with the circulation. And it's these issues that increase that mortality after 5 years. So, for example, when we associate death to diabetes, they usually will have had this issue, a stroke potentially, a heart attack, kidney damage, kidney failure. The diabetic foot is where we're going in a moment, but these are the issues that patient, the complications that lead to death, ultimately. So, yeah, it's all the hidden things that are going on in that patient. The diabetic foot is something that we can actually see. So we're going to look now at the foot and the assessment and what we can do. We've finally got to the place where we all joined together to talk about the diabetic foot and what needs to be done. So with regards to our content today, we're drawing a lot on the NICE guideline, which was published in 2015, which looks at diabetes and diabetic foot management. It was reviewed and updated in 2019, so it's a nice reference for us to pull into. Hidden within that guidance is a lot around annual review and foot assessment and foot checks for patients with diabetes, especially linking to that patient with sort of like the thought of the amputation risk that they carry when they've got a foot wound. It's important that we acknowledge that we need to look at that patient's foot. We need to acknowledge what is going on in that. And I'm going to look at the next slide. It's going to tell you some of those simple things that we need to be aware of when we're carrying out an annual foot check for our patients with diabetes. We also want to think about the the Charcot foot, we're going to come and look at what that is and what does that mean. Obviously, it's a condition of the weakening of the foot bones, which allows that, well, makes that foot collapse, dislocate, fracture, etc. I think the key message throughout all of this presentation is you're not expected to manage these patients alone. It's all about assessment, early diagnosis or early referral. A multidisciplinary approach is what's needed for the management of these patients. And that links a little bit back to what I was just saying around when I saw the patient with a foot wound, the referral came into me as tissue viability, I'd be like, oh my gosh, I know the pathway of care for the diabetic foot patient is much more complex and easier for me to access than the patient without a diabetic presentation, whereas foot challenges, foot ulceration needs specialist involvement. There's always an underlying cause, peripheral arterial disease, neuropathy, that can be compromised in those sort of patients. Act early, refer early is where I'm going. So when you're seeing your patient, seeing clinic, or you're assessing a patient's foot, what do we need to look for? It's important that we acknowledge things that we can do well and the things that we might need more specialist input in. We want to sort of look at a patient's foot on an annual basis, but we also need to empower our patients to act in between those assessments. So patient education is really, really important. If a patient sees a wound on their foot, they need to escalate that. If a patient has been admitted to hospital with a foot ulcer, then they will be seen very quickly within 24 hours of admission by a specialist multidisciplinary team within the hospital. So it's important that we do that for patients within the community setting. So if you have a patient who's got diabetes, they come into the clinic, then you need to refer them immediately into the appropriate services that sit within your area. Sadly, everything differs and changes. The guidelines, the NICE guidance says, within 1 working day of a patient presenting with a diabetic foot, then the person needs to have an examination by a multidisciplinary foot clinic service. We know that's what NICE guidance is all about, and we know in clinical practice what the barriers to that are and whether that's actually in place for our organisation. So my message is know the system, know where to refer, know who to access, and know your pathway of care for your diabetic patients with a foot ulcer, but also the patients that don't have that diagnosis of diabetes. Never forget to check though, the patient that presents with a foot wound, exclude diabetes, type 2 diabetes straight away, or conclude that they have it. With regards to that though, they do want to see in the pathways of care those patients that don't present with a diabetic presentation. So with regards to our guidance, we focus a lot on NICE guidance, but also what the National Wound Care Strategy has very recently pushed out in 2023, last year. And I'll share the links in the chats and make sure you get these as follow-up, the links to these guidances. National Wound Care Strategy is supporting what NICE is saying, that we need to assess these patients. We need to look at these patients' feet. Something that we can do in clinical practice, something very simple, is assess the patient. Is there any sort of wound? Ultimately, signpost straight away to the appropriate multidisciplinary focuses. But then get the patient to care for their foot. We want to prevent any wounds. It's all about good footwear advice, avoiding calluses, getting podiatry involved early for these patients, because these are the things that will prevent the foot ulceration in the first place. And, looking at that top one, neuropathy, we're going to come back to that in a moment, look at it in more depth. And as you can see, there's a 10-gram monofilament probe there that they're using on the right-hand side. Doesn't need much training, but ultimately you need to know how to use that. That's looking at whether the patient can feel the foot, because we're going to look at that in a little bit more depth. That's a huge one when we're looking at trauma, foot ulceration. These patients are not feeling the wounds that are presenting on their foot. So I've really thrown a lot of information there around sort of diabetes and the assessment part and those early assessment, early referral in and what we can do. I think it's important to empower our patients. We talk a lot about, empowerment. This is a lifelong condition. They've got to live well over time. They've got to acknowledge, and I know the challenges that you face with this. They've got to acknowledge what is happening to their feet and why they need to seek help. So this is a tool that's used a lot with regards to Act Now, allowing that patient to assess and know when to get help with regards to what they're feeling and presenting. With regards to the NICE guidance, and that guidance that's come out in 2019 was updated, it's the NG19 on the NICE guidance page if you really wanted to quickly look into that. But again, we'll share the link. It talks about the risk of amputation a lot, and it classifies and stratifies patients that are at risk of an amputation. Those patients at low risk are the patients that, have no real risk factors and present perhaps only with a callus, some dry skin on the foot. Those at moderate risk of amputation are classified as those with a deformity, so as in the Charcot foot, which we'll look at in a moment, neuropathy, which I'm going to explain what that is, peripheral arterial disease, again, I'll explain what that is. So those patients presenting in that way are at moderate risk of moving on to require amputation. It's their risk status. The patients at high risk are the patients that have previously had a wound or are presenting with a wound, ulcer, or ultimately had a previous amputation. Sometimes patients will have a toe amputation, but then it goes to the foot, below knee, moving up that leg. So, those patients that have previously had ulcers or previously had amputations are very much at risk of high risk of a further amputation. And, those with peripheral arterial disease and neuropathy, as in that patient presenting classically with those risk factors. The patient with an active foot ulceration, active diabetic foot problem, that's your top one. Those are the ones that, red, blue lights, thinking they need action, they need multidisciplinary involvement, and I'm sure you've all got examples where you are working closely with Diabetic Foot Clinic. The clinic that I worked closely with was called the Diabetic Limb Salvage Clinic. And I remember questioning at the time, what a brutal title for a clinic. And I'd have the patient that I'd say, I've assessed you, I've referred you in, you're going to go to the Diabetic Limb Salvage Clinic. Patient would look in horror. However, when I questioned this further, it is true. At that point, when a patient has a wound, a diabetic foot problem, wound or ulceration, it's about time. It's about working against time to salvage, to prevent that patient having to have that amputation. It's working together to ultimately prevent that happening. So I think it's all about act now, like this says for the patient, but really do embed in your thinking the seriousness and the need for early, like we looked at with the NICE guidance, early assessment, early diagnosis, early treatment from a multidisciplinary focus and foot service. So now looking at those patients and the risk of amputation, diabetic foot ulceration. Why are we here today? We're here today to look at how it occurs and what causes it really to occur. These patients, I want to take you back to that little slide that I put up, and I talked about high blood glucose levels damaging the vascular system, the circulatory system. So the macro or the micro, the big blood vessels or the small blood vessels are all compromised. We looked at that slide that showed strokes, heart to heart, kidneys, eyes, going down to the foot. It's all sitting with the circulatory system. High blood glucose in the circulation damages the blood vessels. Simple as. What high blood sugar also does, though, is it damages the white blood cells that help with a patient's wound and infection. So those big cells being the macrophages that we talk about a lot, those white blood cells, think of them gobbling up bacteria in a wound. They are the function of those is damaged by high blood glucose levels. So it's not a great story, and these are some pictures here of some wounds that present on patients with diabetes. So thinking about that circulation, stay with it, because that is one of the main issues that patients have. Peripheral arterial disease, the damage that's happening within the circulatory system. So, this damage that occurs from this high level of the blood glucose. That's why we talk a lot about, patients with diabetes. We want really tight glucose control. So we want that really tight, the best we can possibly get it. And I know the challenges with that. I've been in clinical practice a long time, but it's about empowering the patient and giving them knowledge to make those either unwise decisions, if they've got capacity, or acknowledge what we're saying and move with that advice. So the tighter the glucose control, the less of an issue that patient's going to potentially have with those complications. I reflect on my practice. Have I empowered my patients enough in the past? Have I really talked about the mortality that's linked to diabetes and the complications and the strokes and the heart attacks? Probably I've not empowered them enough when I think about my own reflection. They're strong things to talk about, but they need to be messaged out to our patients to allow them to make those decisions. So this slide is showing us the issues that happen in the arterial blood supply. Peripheral arterial disease, simply thinking the blood glucose levels, the damage it's done is stopping the flow of blood to the foot. No blood getting there, tissue in the foot will die. So that's ultimately what's the issue with peripheral arterial disease, is tissue death. Then a wound, an ulcer. An ulcer, all that is a wound that doesn't heal in a timely manner. That's the definition of ulcer. So diabetic foot ulcer is an ulcer, so a wound that doesn't heal in a timely manner on the foot. Diabetes a contributing factor. The reason the diabetes is such an issue is peripheral arterial disease, the damage that that high level of glucose has done to the circulatory system. So a nice thinking there. Peripheral arterial disease is one of those contributing factors to foot ulceration. And then the other one, neuropathy. And we hear about this a lot. What exactly is this? And this is to do with the damage that the high level of glucose has done to the nerves. It's damaged those nerves. Nerves in the foot, nerves all over the body. We've looked at the eyes and we've thought about the kidneys. The nerves everywhere, not just in the foot. But today we're focusing on the damage that's been done in the nerves to the foot. They can't feel pain. They don't know there's a wound. They don't know they've stood on something. They don't know there's a callus there. And that patient with damaged nerves from the high level of glucose, as in the circulatory system to the nerve is an issue, so the nerve just doesn't respond, then is a dangerous place for that patient to be. And that's there with that monofilament 10-gram probe there, checking to see if the patient can feel very light touching. And if they can't, then there's an issue there. But neuropathy, they'll tell you, or you'll be aware, just touching. If they can't feel you touching the foot, that's a concern to you. Escalate definitely to get a full review, because it is one of the indicating factors that will contribute to the development of diabetic foot ulceration. Okay, so neuropathy. And then the big one is trauma. So from our patient's perspective, trauma itself is what's going to damage the skin, as in loss of continuity of the skin is a wound. So if you imagine you've got a sock on your foot, that's your skin. Your sock's your skin. Break the sock, there's a risk of a wound developing, infection, etc. So this is just a flow chart that happens a lot with diabetic patients. So patients with diabetes sustains an injury, a trauma, stands on something. And I've spoken to some podiatrists, and there's some horrific stories around patients standing on clunks. I mean, that is painful. If you've ever stood on Lego, that's painful. And they're not feeling it. And then that wound is left to progress because of neuropathy. They're not feeling it. So step on anything check your shoes before you put them on. There's good advice for diabetic patients that potentially can't feel their feet, because check there's nothing in there, because the trauma is what will cause the initial onset. And then that foot also will develop and progress because of the reasons we've looked at: peripheral arterial disease, blood getting to the foot, neuropathy, and then potentially the outcome there, the end of it will be that potentially leads to a limb amputation. It's the cycle, a simple cycle really, but one that we really need to acknowledge with our patients and say, got to look after your feet, got to make sure that dry skin doesn't crack and break and cause this loss of continuity of the skin, breaks the sock of your foot because you're on a slippery slope to potential amputation. And so when we think of amputation, and people, some of these statistics on this slide in front of us are just really mind-blowing. People with diabetes are 23 times more likely to have an amputation than someone without diabetes. An amputation takes place every 30 seconds due to diabetes-related complications, and that could be a patient that's like just having more of the limb chopped off, so to speak, because they need to, remove that tissue. It's dead, it's causing infection, more risk to that patient. More than half of the diabetic patients' foot ulcers become infected. We're going to look at infection in a moment. And those infections can really lead to the ultimate amputation. Bone infections, osteomyelitis used to be the absolute bugbear in my clinical mind, in clinical practice. Wherever you see bone, think osteomyelitis, bone infection. You've got a patient with diabetes with a wound and you can see a bit of bone in there, that's the ones to panic. They're the ones that are going to potentially have bone infections, which results in amputation. Taking you back to the beginning, where we looked at mortality, these patients are more at risk of dying, especially, when they've had those amputations. It's a lot to do with those other issues, though, that we talked about. We're focusing on the amputation, but they've got all of it going on, haven't they? They've got it going on in all their macro circulations, so their brain, strokes, hearts, kidneys, never far away from the bigger picture when it comes to patients with diabetes. So with regards to these patients then, it's all about us trying to, you saw that trauma cycle that led to the potential amputation, reverse it, really play our part in that role. And it does all come back down to awareness, observation of the foot, educating the patient, and early signposting into this multidisciplinary foot service pathway that I would really encourage you to explore what that looks like for your organisation. And it will look different in different places, so get really familiar with it. The ones that we can sort of think around, though, is what will help us to indicate the severity of an ulcer that presents to us. And there's some big ulcer severity indicators. We're just going to explore them. We've looked at them. We know we've looked at ischemia, dead tissue, peripheral arterial disease, circulation not getting to the foot, causing tissue to die. We've looked at neuropathy. We're going to look at in a little bit more depth at the other ones, but they're all common sense when we've looked at the content of the module before. So with regards to our patients, big wounds are never going to be great. Big, deep areas of tissue loss, more at risk of infection. I touched on that bone infection, osteomyelitis type thinking. So these are the ones that almost will be the ones that will really make you think, oh, I need a bit more help with this. I need to signpost. However, in diabetic patients with diabetes, a small, tiny little break in the skin, before you know it, with all those complications, can be a deep amount of tissue loss. So, don't think just a tiny wound is not going to become a problem. It really, really does. But the big ones are a real problem already. So with regards to the other indicators, ischemia, this is the one. This is peripheral arterial disease, lack of circulation, tissue dies. But not only does the tissue die, those cells that rebuild wounds, those fibroblasts and those cells that really fight infection, those macrophages, they can't get the oxygen and the nutrients that they so desperately need to allow that wound to progress. And then don't forget neuropathy. It's a huge, huge challenge to these patients. They can't feel those wounds developing. The message today, though, has to be that a lot of the time patients get ulceration due to a combination. Just 1 second, sorry. Combination of ischemia and neuropathy. So in isolation, neuropathy itself doesn't necessarily cause a major ulcer. It's the presence of both. Neuroischemia is the posh word, but it just means the patient has both. They have neuropathy and ischemia. They coexist a lot of the time in patients with diabetes and ultimately result in these presenting with ulcers. Can't take you far away from that huge, massive risk of infection. Here at Essity, we do lots of great modules on the infection continuum. What is infection? What is wound infection? How do we recognise it? When do we act? Today was all about the diabetic foot, but wound infection itself is very much around being able to recognise when a wound is infected. This can be a challenge in a patient with diabetes, though, because one of the main indicators will be wound pain. So the patient will go, do you know what? This wound is a lot more painful than it was last week. With diabetes and neuropathy, they can't feel the pain in the same way. And, we know that the circulation to that wound is not necessarily there. So the erythema may not be presenting. So the infection can present in a spreading systemic way and be masked that local infection where it's just a bit of a bacterial load is a bit high in the wound. It, can be not easily acknowledged. Before you know it, the patient has a real spreading systemic infection. So what we'd say on wound infection is it's one of the main contributing factors to that patient going to hospital and requiring interventions, amputations, that word we've been really exploring throughout today's session. So it's all about getting antibiotic interventions and antimicrobial interventions onto this patient as soon as you can detect infection. The colleagues at Essity, they have lots of products to support with bacteria burning management. You'll have heard of some of them, probably some of the Cutamed Sorbax assortment. That will have its role with lowering bacteria in the wound, because these patients we know are at risk of infection. But you don't want to wait necessarily till they have an infection to do. So some of the dressing technologies binds bacteria, and their principle is a physical mode of action to continually support that patient with bacteria burden management. So infection, hopefully, the risk of infection is being addressed and reduced, because infection is what will lead to that amputation. So I've done a real whistle-stop tour of lots of content there. I'm conscious that we only had an hour together, and I know I've thrown a lot at you, but the one I just wanted to look at, which I admit I knew nothing about, I couldn't even say the word Charcot for a lot of my career. What does that actually mean? But I've seen it in practice. I've seen the patients with diabetes with really deformed feet, but I've never really known why that actually is. The Charcot foot can affect people with neuropathy, nerve damage, and what that means is the bones in the foot become very fragile and they start to break and dislocate, and just pretty much deformed foot appears in front of you. The commonest cause of Charcot foot is diabetes, so it's a good indicator. However, you can see it in patients that don't have diabetes as well, but it is more common in those patients with diabetes. And it becomes an issue when you're thinking about footwear and you're thinking about those patients that are going to need some support with their footwear, because these patients, if their footwear doesn't fit, it's back to that trauma cycle, causes like a pressure ulcer on the foot that then obviously with peripheral arterial disease and neuropathy escalates very quickly into that severe ulceration and that risk of amputation. So footwear and the deformed foot definitely needs to be looked into, and getting that patient, even with a severe Charcot foot, we need to offload all the weight on that foot. And you probably may or may not have been aware that they do a lot of in casting rooms, you might have seen patients with sort of like offloading devices, boots on that foot to take any pressure off that deformed foot. So a recap, Charcot foot, due to the neuropathy, the collapse, the deformity, the fragileness of the bones just cause a different presentation of the foot. You can see, and this is a classic picture. I've seen so much of this in district nursing, and a lot of my career I didn't really get that was due to the contributing factor of diabetes, the Charcot foot presentation. They can be warm and hot, inflammations present in that foot, they can be painful and sore, but it's all about this, don't let that deformity cause more damage. Offloading, good footwear, and make sure that patient doesn't sustain any sort of injury, trauma, as a result of that foot being in the deformed shape that it is. That's just a nice picture there of some offloading devices that you may or may not see, and that obviously needs multidisciplinary referral in. We have a lot of education at Essity under our Path Orthopaedic learning plan around, what does that look like? How do we create that? We do have clinicians in the community using casting materials to do this. However, a lot of it is owned within podiatry or casting clinics. So we're coming to the close of that presentation, but what really I want to highlight today is, it's all about assessment and awareness, and the guidance is out there to support us. But what can we do? It's having the knowledge that we've looked at today, but it's looking at sort of like the patient as a whole, holistically, examine the foot, look at the foot, but also educate the patient to be aware of that sort of like cycle that can occur with trauma. Understand that neuropathy and ischemia or peripheral arterial disease is a big issue for these patients. So know if that patient has got a blood supply to the foot, it'll present in that way. We use a little bit of ABPI sometimes, ankle breaker pressure index. However, that can be a little bit distorted in patients with diabetes. But, duplex scanning, have they got peripheral arterial disease? The multidisciplinary team, is it a diagnosis that we've got for this patient? They're the ones to be alarmed and to really focus our thinking around. And don't get around that sort of like the management of that foot, Charcot foot, deformed foot, offloading, and manage all the diabetes focus. We focus today on the foot, but it's all about the big glycemic control element that needs to happen. Those guidelines that I've talked about a lot today really do support us. Everything that I've sort of introduced today is built within the National Wound Care Strategy Programme, guidance on the foot, and also the guidelines from NICE. It is all about in NICE, NICE guidance around early prompt referral to specialist services. Remember that one working day ideally is the ideal that we're working towards, and I know how challenging that can be, but that can just be seek out support. Don't manage it alone. Don't just say, oh, it's just a little wound on the foot. It'll be fine next week, because the chances are with that escalation, it won't be fine next week. And those risk factors to those patients with that presentation, that risk of amputation is so, so great. So with regards to the closing slides, it's all about what are our red flags? What are our red flags to making sure we escalate our patients? Infection and sepsis links to that. So that's going to be like sort of like spreading systemic infection, chronic limb-threatening ischemia, unexplained inflammation of the foot that could link to Charcot foot, ulcers, deep tracking, and lower limb vascular issues and skin cancers. Those are red flags that fit in the National Wound Care Strategy. Bizarrely, we're talking about diabetic foot, and we've got DVT and skin cancers in there. But sometimes diabetic patients can present with very strange ulcerations, and it's like, does this need dermatology as well in there? And obviously, it's very difficult in diabetic patients for them to explain pain, and deep vein thrombosis is quite common. So we need to think about escalation very quickly. And our little flow chart says here, escalate immediately if you've got any of those red flags present. Clean the wound. An element of debridement. Debridement in diabetic foot management is huge, but I'd say definitely involve the specialist referral in there, because if a foot hasn't got any circulation to it, you don't want to start debriding tissue, because you'll just make everything so much worse. So vascular input is needed with these patients. Recording and documentation and dressings and offloading. So the pathway that we implement in primary care is one that we do with lots of other things. It's being aware, recognising, recording, escalating and referring, and then doing our bit to prevent deterioration. But getting the patient on board is the absolute must. So we've got to live well over time. And this is probably the hardest bit, because we've all got patients that, ideally we know, and through this education today, we know what we need to do, and they'll still be having their 4 pints a night and poor diets and coming in and saying, I've got a little bit of problem with my sugar and I've got a sore on my foot. And we all have those patients that, we're trying to empower, that have got capacity. They've got capacity, they're making unwise decisions despite us giving them all the knowledge that they need. So, we have to do our part, but documentation in those patients is absolutely vital. And we've moved our thinking from self-care to supported management. We don't want to let the patient think that they're left alone. We want to be in partnership with them. And I'm very conscious of time, so waffle too much. So I want to give us five or 10 minutes for questions. So I just want to conclude what we've looked at today, because I've thrown so much your way. Let me give you the real simple takeaway messages. If you take nothing away today, I hope I've empowered you and developed your thinking around how to simply think about diabetes in a busy world that we're in, where we've got so many other things to focus on. Think of diabetes in that keys to the cell thinking. High levels of glucose, we eat our food, it's absorbed into the bloodstream, and the pancreas produces insulin. The keys to the cells. The insulin opens the cells up, allows the glucose to go into the cells to do their job. With type 2 diabetes, those keys are working frantically over time, and for all those other reasons, but they can't work as well as they could. So you get this build-up of glucose in the bloodstream. Type 1 diabetes, no keys at all, no insulin. So again, that challenge is there's no keys. So the blood glucose goes up and high, and they really diagnose those patients. It's all about, has the patient got keys to open the cells? Yes or no? And are they working? Yes or no? That's my simple analogy today on what diabetes is. I don't want to bombard you with all the technical elements and the heavy literature. Keep it simple in our heads, because then we can communicate it to our patients. We've looked at what we can do. We know that we need to acknowledge these patients, and we know we need to empower them and give them knowledge around that cycle, trauma, breaking the skin, breaking the skin that they have on the foot, peripheral arterial disease, blocked arteries, problems with the vascular system, not enough blood getting to the foot to bring all those good cells, problem, neuropathy, they can't feel anything. So a small break will escalate very quickly in these patients. Signpost early, know your pathways of care, and get them the appropriate treatment that they need, which is that last objective. So from all my waffle and content that I've given you, there's some real simple messages in there that we're all looking after patients with diabetes. We all need to play our part, but we're not alone. We need to escalate. We need to really make sure they get the best care that they can, and know your systems within your organisation for referral. So there's a little QR code there. I know I've not left much time, but if we zap that, if you want to zap that, then you can give us some feedback, but we will push that out after the event. Tons of references that the module's built around. Like I say, National Wound Care Strategy and NICE. But I know Kieran's going to absolutely challenge me back now, because I've just looked down at the clock, Kieran, and I'm conscious of the time. I've not left much time, have I, for questions?
It's okay. That was such an informative session, Jane. So yeah, just thank you very much. Yeah, we do have an opportunity to cover some questions. So if you do have any questions, please pop them in the chat now.
Yeah, I'm conscious that we did waffle a lot on, and if we don't get many questions, that means that we've covered content that people are wanting, Kieran. So that's good.
Exactly. I was about to say such a good job with the informative presentations. No questions required.
So that's
So
good then. So I'll pull up your next slide, and then I'll go off
yeah.
camera if that's everything from me. So there you
The
go.
only question I would have had, Jane, is so just in terms of nice guidance, the Act Now tool you covered,
Yes,
and the
yes,
path learning plan, it would be really great if we could share these with
absolutely.
everyone. So we'll pop those together for everyone.
I absolutely will. I'll share links to the NICE guidance, because these are real strong guidances that really do help us and support us if we ever get challenged in practice, and also the National Wound Care Strategy thinking our path learning plan absolutely will as well. So there's so much extra learning that's out there.
Okay, so I hope you've all enjoyed and found this webinar valuable. Over the next few weeks, you will receive your certificate for today's module, along with some dressing samples for you to take a look at. So that's everything from us today. Thank you for joining, and enjoy the rest of your day.